How's it going? Good, good. All right. So I'm a respiratory therapist. I'm the clinical specialist within our hospital. So in that role, like I never take assignments or anything else. My big board for the day is populated by consults, essentially. So I consult on all the complex mechanically ventilated patients throughout the whole hospital that just happen to include the ECMO patients. So our model right now is that perfusionists sit pump, and the therapist still, and myself, still kind of manage the ventilator side. But my main role is through respiratory therapy and mechanical ventilation. I do a ton of education, a ton of lecturing all over the world and that sort of stuff, okay? So that is my expertise in my wheelhouse and what I usually talk on. One of my favorite topics is lung protective ventilation and how to go about doing this. So it kind of fits right into this niche with what we're trying to do here, okay? So we're gonna go through these slides here. Let's get some of the legalese done and over with, I guess. My conflicts of interest, I do consult, I do speak, and I do a bunch of different writing for educational curriculums and textbooks and that sort of stuff on mechanical ventilation. So those are my legalese, conflicts of interest. Everything that we have here that I have for you is all my stuff. It's not representative of anybody else, Perfusion or any other associations. Cool? Legalese? All right, this is one of my favorite disclosures. I'm not sure, you can read it. So there's a gentleman named Luciano Gattinoni. He's from Italy, if you hadn't guessed and put that together. He is a titan in mechanical ventilation and ARDS research. If you Google his name, you'll get 500 some odd hits type of thing on cutting edge mechanical ventilation and physiology with a whole bunch of different pulmonary slants and that sort of stuff. So he has this article that was published about 5 years ago, how to best set up the ventilator while on ECMO. And I'm not sure how much you read within the literature, you know, as opposed to skimming abstracts and that sort of stuff. But this is probably the single best introductory statement to any paper I've ever seen. If you begin to read this article while hoping to find an evidence-based answer on how to set up the ventilator during ECMO in patients with acute respiratory distress syndrome, we suggest you stop reading here. All right? So that's where we are. That's where we are. We are still in this kind of exploration and trying to figure out, you know, through prospective randomized controlled trials, how to best set this stuff up, okay? So, however, physiology and previous experiences and experimental data do exist and may help to design a reasonable scenario in which you can try to protect the lung, essentially, is what he's saying, all right? And so this is the argument that I'll make kind of all the way through. We know enough, like what not to do in a bunch of different situations, and we know how we hurt the lung and that sort of stuff. And we just kind of got to translate this through for now until we get some big randomized controlled trials going and that sort of stuff, okay? Good enough? So my goal is to kind of break this down as we go through, explain some of the baseline modes of mechanical ventilation, just a really organizational type of sense. You know, what are control variables and that sort of stuff. Then I'm going to go into processes and etiologies and things that happen for ventilator-induced lung injury. And then we'll talk about those strategies, how to stop doing that. And then finally, we'll put it onto the vent, that whole crop of ideas, put it onto the vent when the patient's on ECMO, okay? Sound good? All right, so we'll get started as we go through the fundamentals of mechanical ventilation. So, you know, this is always a difficult talk because I'm not sure where to come in. You know, I could breeze all the way by this and not even mention it and just go straight to the other stuff, right? So how comfortable, if I were to say on some sort of rubric, 1 to 10, 10 being the most comfortable type of thing, type of rating with mechanical ventilation and knowing what's happening, scale 1 to 10, who is like a 0 to 5? And I don't know you, you're fine. You're anonymous in front of me, so about a 0 to 5. We have a 5 to 10 group. Okay, do we have any 10 plus? All right, good deal. Well, that's okay. I'm a 10 plus. I'll admit I'm the expert on this one. All right, so I feel good about that. All right, good deal. All right, so we will address some of the 0 to 5s, and then we'll move right into the 5 to 10s. Okay. In terms of the fundamentals of mechanical ventilation, the way that this is set up, that machine can only do 2 types of breaths in terms of delivery to the patient. One is a mandatory breath and one is a spontaneous breath. That's it. And it's pure simplistic way of trying to organize what the ventilator is doing. I will tell you, as we kind of start to go through this, I sit on an FDA committee for the taxonomy and nomenclature of mechanical ventilation. Sounds super geeky, and it totally is. But the reason why that FDA group is kind of coalesced is because right now there are 298 registered modes of mechanical ventilation in the US at the FDA. There are 298 modes. There's not 298 modes. The ventilator companies and the device companies are under no rule or obligation to standardize nomenclature. So they can call it whatever they want. And it's a huge mess. And so when people kind of tiptoe up to mechanical ventilation, it's somewhat intimidating because there's so much. It's all boiled down to a couple different ways that you can do this. It's got 298 names for them, all right, but it's boiled down to a couple different ways. So this is kind of our foray into this. You can do mandatory or spontaneous breaths. And at that point at which you select a mandatory breath or a spontaneous breath that the ventilator is going to deliver, you then have to kind of tell the ventilator or understand what the ventilator is doing if you're walking up to it. What is the pattern in which this mandatory breath or this spontaneous breath will then be delivered to the patient? And so the pattern, what I'm trying to talk about here is that if the patient isn't breathing, they are completely apneic, they have no respiratory drive, well then clearly they're not going to be participating with the ventilator, and the ventilator is going to be set up to deliver a certain amount of breaths to the patient every single minute, a rate of 10 or a rate of 12 or a rate of 15 or whatever have you. Right? And so when the patients are apneic, it's hard to tell, kind of separate out the noise, essentially. However, the real question and the real kind of organization comes, well, what happens when the patient does breathe, right? What does the ventilator do, or how does the ventilator react to that scenario? And so if the patient goes to take a breath, and the ventilator senses that, and at that point delivers the same mandatory set breath that you had previously when they were not participating, what you end up with is a pattern of breath delivery that every single breath is a mandatory ventilator breath. And so they're all mandatory, and this takes on a moniker or a name or a mode that is assist control. All right? So when you say, or when you hear the patient is on assist control, what that means and what it says is that all the breaths are mandatory breaths. Whether the ventilator turns it on in the case of apnea, or whether the patient asks for the breaths, they all look exactly the same. They're all mandatory breaths. Okay? Different than, let's say, if there was a mandatory breath and then the patient were to go to take a breath and the ventilator responds by delivering not a mandatory but a spontaneous breath. So then you have this mix or a completely different pattern of breath delivery. And so that's what a mode tells you, is what is that pattern of breath delivery? And in this case, the most common one is assist control, meaning they're all mandatory breaths, okay? Once we then say, all right, we want the patient to receive all mandatory breaths or be on the mode assist control, you then have to tell the ventilator, or understand what the ventilator is doing, is how is each one of those mandatory breaths being delivered? So there are a couple different ways. You can choose to set the tidal volume, or how much volume goes in with each one of those breaths. And so every single breath, being that they're the same, will now be delivered at the same tidal volume, whatever is set. And that occurs whether the ventilator turns it on in the case of apnea, or the patient is turning some of those breaths on. So if the vent is set at a rate of 10 and a volume of 500, clearly they're going to get 10 breaths at 500. However, if the patient breathes up to a rate of whatever it is, 22, something above that, that is fine, but all 22 of those breaths will be delivered at 500. And then therein lies your mode description. They're on assist control with a set volume, okay? Good enough? There is a there is this option in which you can choose to set a pressure instead of a volume for each one of those mandatory breaths. And so the pattern looks the same. It's just if you plucked out each one of those individual breaths, they would behave differently, one being with a set volume and one being with a set pressure, right? And so the pattern is assist control. The second part of that description is how you deliver the breath. So you essentially have VCAC, or volume control assist control, or pressure control assist control. All right? And therein lies the generic naming for that, regardless of what that ventilator out there decides to call it. Most of them are kind of coalescing around some like scenarios in terms of naming, but this is what the generic naming would look like. So you can be on ACVC or ACPC, and what that translates into all mandatory breaths with either a set volume or a set pressure. Okay? Good enough? So that is on the mandatory side. There's a couple other little fancier ways to do it with volume targeted pressure and that sort of thing. We'll kind of put those to the side for time purposes and that sort of thing. Let's look at the spontaneous side of this. Well, before we do so, let's talk about the settings, the nitty-gritty settings of each one of them. So I like to really divide my brain in half, one side for oxygenation, one side for ventilation, because in these modes, they are decoupled from one another. Meaning my oxygenation settings are an FI2 and PEEP in this mode. And if I want to correct oxygenation, those are my go-to controls, essentially. If I had a CO2 problem, they do not cross over, essentially, is kind of what I'm getting to, right? So an O2 problem demands a PEEP or an FiO2 change, or on the ventilation side, a CO2 problem demands a rate or a volume change. And if you had hypoxemia, you would not increase the rate or increase the volume because it's not going to fix O2, it fixes CO2. So therein lies the organization in terms of the nitty-gritty detailed settings within VCAC. All right? If we looked at PCAC, you have the same logic in which you have oxygenation settings, which are the same, PEEP and FiO2, but the ventilation settings, clearly you don't have a set volume, you have a set inspiratory pressure. All right, and so you have rate and inspiratory pressure in terms of how you fix things or how it's organized on the machine. All right? If I add the spontaneous types of breaths over on this other side in our organizational chart, you have a couple different ways to do this. The really at the very basic core of it is that the ventilator doesn't have a set rate anymore, meaning the patient has to take a breath. They're only spontaneous ones, right? There are alarm backups and apnea backup settings and that sort of thing in the event that the patient does stop. But in the course of life, essentially, the ventilator isn't going to deliver any breaths unless the patient demands it, and it will then therefore be a spontaneous breath, okay? So the first way to do this, the most common way, is something called CPAP, or continuous positive airway pressure. And that is a way in which we just set a baseline pressure. All right? We don't let the patient breathe on zero pressure, we let them breathe on something above ambient pressure. All right? The ventilator provides no assistance to them whatsoever at all above that ambient, supra-ambient pressure. It provides no rate, and it provides no volume, and it provides no augmentation of volume. Patients completely on their own. They only get to breathe on an elevated baseline pressure. You and I have built-in PEEP within our lungs because our epiglottis closes. We don't exhale all of the gas that is in our lungs, so we trap some of it at the end of exhalation, and we have surfactant. So we have built-in PEEP, and it approximates about 3 or 4 centimeters of water in the adult. And so usually you typically see any ventilator, we have to mimic that for them, for these patients that are intubated. And so they have 5 of PEEP or 5 of CPAP. And that's just normal restoration of physiology. And so in CPAP, all I'm doing is setting 5 of pressure and letting them go. They're completely on their own. That's essentially what I'm trying to say there. The other way that to deliver a spontaneous breath is to somehow augment their inspiratory effort. So let's say that you had a patient that is on CPAP. They're breathing all by themselves, but they're getting kind of little wimpy volumes. They're not taking very big breaths at all. The ventilator can sense the patient's inspiratory effort and then deliver some pressure during inspiration if and only when the patient triggers, and it will augment their volume or make it larger for them. That is called pressure support. So there's two ways to do spontaneous modes or spontaneous ventilation. One is CPAP, they get nothing. One is pressure support, they get some help, some augmentation. Neither one of them have a respiratory rate attached to it, okay? So that is the organization behind that, all right? In terms of the controls for oxygenation versus ventilation, oxygenation are all the way through the same, FiO2 and PEEP, and it's regardless of the mode. The way that you control the ventilation is a little different per mode, all right? And in this case, in pressure support, I don't have a rate there anymore, as we kind of refer to. I only have the inspiratory pressure, how much I want them to get during that inspiratory effort, all right? And so what you end up with is this kind of organizational structure in which you have some mandatory modes or ways to deliver a breath, and you have some spontaneous modes. This does not kind of include this structure, this APRV or airway pressure release ventilation, all right, which is kind of gaining some traction. There's some evidence within the literature that is showing some kind of clinical benefit to it. Nothing on the mortality side, I'm talking off of ECMO, nothing on the mortality side that, you know, makes me want to use it all the time in everybody, but you have select types of patients in which this would be really, really beneficial, a way to provide mechanical ventilation. The way that it works is that when I put a breath into a patient, just any breath, I do all of my good stuff kind of at the end of inspiration, if you think about it. That is when my lung is fully inflated, and at that end of inspiration, there is a pressure that is involved with that. And so if I think about it and contemplate it, if I do all of my good stuff with that inspiratory pressure at the end of inspiration and I have my lung fully open, why don't I just put it in and leave it in at that particular pressure and kind of leverage that, you know, advantage of my lung is fully inflated at that point. And so what APRV does is do that. The pressure goes in, if you can see the scalar graphic there, the pressure does go in and then it's held for an extended period of time, meaning 3, 4, 5, 6 seconds types of things, right? And that promotes alveolar or lung recruitment. What you run into is that you still have to somehow exchange fresh gas in and out. And so what happens is that I put that pressure in for a designated length of time called the T-high, and I have to release the volume or the pressure out of the lung. And what it does is it goes down to a lower pressure. So you essentially have two levels of pressure, a P-high and a P-low. And what that transition from the P-high down to the P-low does is really just exchange fresh gas for you. Otherwise, I would keep the pressure high all the way through and try to get away with something like that, right? Okay, so that transition down is for the exchange of fresh gas. The bad thing that happens when you go down or transition to that lower pressure is now the lung goes to deflate essentially. And you don't want it to completely empty out. And so that time frame at which the pressure drops to the P low is extremely short, meaning like less than a second, typically 0.5 seconds or 0.3 seconds. So it doesn't let the lung completely deflate and completely empty, and it preserves some stability within the lung that it doesn't collapse all the way down, all right? I just need to get some fresh gas into them, out of them, and then back in, okay? And so that's what the function of that P-high and the T-high, good alveolar recruitment, and then the transition to a P-low and a T-low, exchange of fresh gas, but at a short enough period of time that my lung doesn't completely deflate. Those are the functions of those settings. The unique way that this happens is that while the pressure is being held, the patient is allowed to spontaneously breathe at that P-high. And it's actually a good thing to let them try to do that in most scenarios if they can do it without a whole bunch of work involved. And so that is unique to this mode, because if I were to try to put a set volume in and the patient starts to do something other than accept my set volume, the machine doesn't do well. There's a dyssynchrony between the machine and the patient at that particular point. And I got to design that breath better to do what exactly the patient wants. here in this, I put the pressure in and I'm holding it for an extended period of time, and now the patient is allowed to spontaneously breathe as well while on that higher level of pressure. So it's a really, really unique mode. It's super nuanced. You know, in my institution, we use it and we use it quite a lot, but there is a huge number of attending level physicians that are like, I'm not so sure about how to manage this all the way through, all right? And so that is common as you kind of get out and like start to use APRV, and they're like, you get a smattering of people that are pretty good at it, and then there's a whole bunch of people equal in size that are like, I'm not so sure that I want to do this because I'm not so sure about the whole thing. Let's get out of it type of thing, all right? And so that's kind of the layout for that. I'm gonna skip this because I already kind of talked about that. All right, so I worked with Dr. Zakuk Akram, who spoke yesterday, and he talked some about this, and I'm gonna kind of, I don't know, summarize a little bit of what he was saying. So as you talk about ventilator-induced lung injury, what you really, really have to kind of wrap your head around is what you care about now, all right? Because in typical mechanical ventilation, you care about correcting the blood gases, making the PO2 good and making their acid base okay by way of PaCO2. However, when the lung starts to become more and more injured, we really, really move away from that philosophy, more so to try to tip the scales to, I don't care about correcting the ABGs, I really worry about protecting the lung now, all right? And it's a totally different mindset. And so I leave the gases all alone. If they're viable, great. All it's gotta be is good enough to live till tomorrow, really is what it is. And just don't hurt the lung. So it's a totally, totally different mindset as you go into that. So in terms of preventing ventilator-induced lung injury, and we can talk about this broadly, but what you really, really have to grasp onto is how that happens. Like, what is that, right? Like, it's a big word, right? And it has a huge umbrella, but how does that happen? How do I cause the lung to be injured? So there's a couple high-level ways. One of them is volutrauma, one of them is atellect trauma, and one of them is O2 toxicity. All right, so let's kind of go through those as we go forward. When I say that I shift the scales, this is some of the clinical data, some of the clinical numeracy that's underneath of that and what I'm talking about. Really, in these severely injured, lung-injured patients, what we do off of ECMO, going towards that way, we are perfectly fine with a blood gas with a pH of 720. That'll make them live till tomorrow. And then we'll figure it out all over again tomorrow, type of thing, right? And so that's what I mean, we totally shift the mindset. We completely accept an SpO2 or saturation of 88%, all right? And so that's what it looks like as we're going towards ECMO, is that we're kind of abandoning normalizing gases and only trying to protect the lung. We get to ECMO when we cannot protect the lung anymore, essentially, is what we're gonna end up talking about. All right, so CT scan slices of a patient's chest, all right? This is mid-lung. On the left-hand side is normal, a mix of gas and blood, and so you end up with this kind of gray, hazy picture as you go through there. What you see on the right is what Dr. Zakuk was talking about yesterday, and he said it multiple times, is that ARDS is heterogeneous. And what my translation of that, I use the word heterogeneous, but what it means is that you have some good lung and you have some bad lung, and a lot of times those alveoli live right next door to each other. So how the heck do I kind of set up a ventilator to only ventilate the good lung and not hurt the bad lung type of thing? You can't be selective in that case. You have to kind of protect it globally, and that's the problem. That's really, really difficult to do. And so if we talk about how much volume, I'm talking about volutrauma now, if we talk about how much volume that I put into the lung, and I put it into a normal lung, and it's able to distribute throughout a normal lung, the pressure that's involved in putting a volume into that big of a space is very little. It doesn't exert a lot of pressure. When the lung becomes injured and it layers itself out in terms of on the bottom in the dependent lung segments, it's really, really tightly packed and super atelectatic and densely infiltrated, that lung is never going to open. It's not going to open until the process gets away. As you work your way up towards the ventral surface, you see that it becomes less densely infiltrated and less focal, and that lung is collapsed right now on that picture, but is able to be open. It's recruitable, all right, if we can get it open. And then what you see all the way at the very top is what looks like normal lung. And so what happens when I try to put a volume in is that it's only going to go in that normal little spot. So if I have the same volume that is going into that little area as opposed to the big area, I'm going to have a pressure problem, essentially. And so what I usually like to say, and what we kind of think about with ARDS, is that, wow, the lung gets stiff. True, but not the whole, as a global compliance, yes, it looks stiff. But what really is happening is the lung is just small. And so that's why we refer to it as a baby lung. It's just small. And if you can make it bigger, then you won't have these problems with injury as we go forward, okay? So the lung gets smaller and smaller, and putting the tidal volume into that little area has consequences because the pressure will be higher. And that's what we call volutrauma. As the patient gets sicker and sicker, that baby lung gets smaller and smaller and smaller, all right? And the chances for volutrauma go up. And so as I draw this volume of gas going into the patient, what you really kind of have to think about here is, when am I putting too much volume into the lung? And there's this line across here that we try not to cross. We tiptoe up to it, and it is the amount of pressure that is exerted because of the volume that goes into that lung, right? And that pressure that we typically think about becomes really, really, really important, all right? And so in our mind's eye, we can't put too much volume in based on the lung size. Now let's think about the bottom end of that lung volume scale in terms of something called atalic trauma. So atalic trauma is when the lung opens during inspiration, but then on exhalation, it collapses. And on the subsequent inspiration, it then is reopened again. And so the lung goes under repetitive opening and closing. That is injurious to the lung because it's not like just, daintily opened. It's ripped open, and there's a shear stress that's involved in it. The injury looks a lot like an aortic dissection type of injury because of pressure and shear stress. So if you put your finger on a grape and you just squeeze it and the skin of the grape splits because of the pressure, that's what's happening. That same type of injury is happening at the alveolar neck and through the alveolar endothelium because of the high amount of shear stress on opening, all right? And so that is called atalic trauma, and it typically occurs in that area of the lung, not in the top part. The top part's already open and it stays open, and not in the bottom part because it just never opened anyway. And so you have that mechanism of injury, and if we put it on a lung volume scale, it occurs down at the bottom. So in your mind's eye, you have problems with too much total volume within the lung at the top, and you have problems with too little volume holding it open at the bottom. And so you end up with these kind of two operating lines. You got to be above the bottom and below the top. And that's where you got to fit yourself in terms of mechanical ventilation, okay? And so why that and how that translates into kind of a picture is that if you look all the way on the left and I'm not setting my PEEP high enough to keep the alveolus open, it's going to be collapsed and it's not going to participate in gas exchange. And then I'm going to get it open and I'm going to find the sweet spot kind of right in between recruitment and distension. That's the bottom line and the top line. But then if I put too much in, then I'm going to kind of tiptoe into over-distension. And all along the way, you have gas exchange abnormalities that happen. And so you will have terrible gas exchange. It'll get a little bit better. And then when you overdo it on the over-distension side or volutrauma side, it goes back to terrible again. And so it really is a sweet spot of mechanical ventilation, all right? The problem is that the patient doesn't have like an indicator on their forehead and says, this is where it lives, set me up this way. And it's hard to find these points for any individual patient. And so therein lies the issue and the problems and complications with this, all right? So, Oh my gosh, it's 2:32. All right, you were gonna let me go all the way over? All right, so to fix this, we have to use less volume in that little spot, essentially. Because if we put too much volume in, it's gonna over-distend. And we have to think about how much PEEP we have set at the bottom to keep the lung open, all right? And that, in case, prevents the de-recruitment or the re-recruitment injury. I'm going to do this for us. Hold tight, because I want to make sure I get to this part, all right? There we go. So these strategies while on ECMO, that's why we're here, right? All right, so these strategies kind of applied. The lung injury is still, like, we still have to prevent that. And really, when we go on to ECMO, there's no reason not to prevent that, right? You're doing the gas exchange portion through the membrane. You just got to get the ventilator set up so it stops hurting the patient in the ways that we just talked about. So as we go through, there's no evidence for this. This is where we're off the rails a little bit, essentially, okay? And we just have to use our smarts and what we do know about physiology to make sure that we're not hurting the lung on the bottom or at the top, all right? And so there are a couple different ways to go about doing this. All of the expert consensus is here within this review article. I'm gonna pick it apart really quick. So within ELSO guidelines, they have this 10-10-10 type of philosophy. They put them on a mandatory mode, whether it's AC or PC. The respiratory rate is set at 10 breaths per minute. And then the pressures, whether it's the PEEP at the bottom that keeps the lung open, and the maximal pressure at the end of inspiration on the top are set up at 10 and 10 as well. And so what you end up with is this pressure graphic that's there on the bottom. That the bottom is 10 of PEEP, and we put 10 of inspiratory pressure in for no more than a total of 20. All right, and so you end up with this kind of drawn up architecture of a breath. All right, so 10-10-10. As you go to REVA, you see the same kind of recommendation, a PEEP of 10 with an inspiratory pressure of 10 for a maximum of 20, but they wiggle a little bit and say 10 to 15 on the bottom, 20 to 25 on the top. Thinking about that lung volume curve, where those dotted lines live, and how you're going to squeeze yourself in. And so you end up with something that looks really, really similar. A PEEP of 10 to 15 and a total pressure of 20 to 25, okay? As you move towards what they used in the Caesar trial, same thing. That's what they did within their research protocol on the mechanical ventilator. Now they weren't testing, the mechanical ventilation wasn't the dependent variable, right? And so this is just what they drew up in terms of the research protocol, all right? And then you move on to the Veolia trial, which used the same 10-10 type of idea, but also permitted the use of this APRV idea, but the numbers weren't anything different. The total pressure is about 20, and then the bottom pressure is about 10. The difference here is that when I select APRV as opposed to AC, is that in APRV, I'm allowed to hold that 20 in for that extended period of time, like what we were talking about in the very beginning. And so the numbers don't look any different. 10 on the bottom, 20 on the top, but that duration that the 20 is held in is for an extended period of time, all right? Promoting lung recruitment. Like 1 minute left? I'm done. 3, okay. All right, so those are the recommendations. I'm gonna quickly go through this because this is a prospective randomized control trial on and with and about mechanical ventilation on ECMO. So there exists this one trial that was designed in such a way to try to figure out, well, how are we gonna do this? And what they did essentially was drop esophageal manometry down the patient's esophagus. We do that, I do it on tons and tons of patients, but if I measure the pressure in the esophagus at mid-lung, in the esophagus that is right behind the heart in a retrocardiac space, esophageal pressure is equal to pleural pressure. It is a validated surrogate for pleural pressure. And so what it does is that it tells me how much the chest wall is pushing in on the lung. Because if it's pushing in a whole lot on the lung, there's not enough pressure on the inside to counterbalance how much that chest wall is squeezing in, the lung is going to collapse. All right? And so what it does, it allows us, in terms of a management, to find out how much PEEP that patient needs. I don't guess. I don't say 10 to 15 and I hope it works. I can measure exactly how much PEEP they need. All right? And so this is a pretty interesting idea, because if I go on to ECMO and I'm just empirically setting PEEP at 10 to 15, and I know that one of the sources of injury is attic trauma, if I let it go shut, then I should probably do something about finding out exactly how much PEEP that patient needs, as opposed to some empirical type of setting. And this is one way to do it, all right? Good enough explanation around what they did on the ventilator. They set the PEEP, but they just set it according to esophageal pressure. All right, so it was a single center prospective randomized controlled trial. It was 104 patients. I only have 3 minutes, so I'm going to kind of cruise through this pretty quickly. They had to, meet specific inclusion criteria in terms of disease severity. Right? And then they excluded a whole bunch of other different ones in terms of duration of how long that this patient was sick. All right? And so the baseline characteristics, as we just point this out, and I have some boxes around some pretty interesting ways to think through this particular prospective randomized controlled trial. The first one is the age. The median age of these 104 patients was in the mid-40s. All right? And so they weren't exceptionally old at all. They were in their mid-40s. Their BMI, this prospective randomized controlled trial was in China. The BMI was mid-20s. That does not exist in North America, right? So just take that for granted, or into your wheelhouse. And then the pre-ECMO ventilator days, in terms of hours, was about 24. So these patients were cannulated extremely quickly. About a day, they messed around and tried to get things right and said, cut bait, let's put them on ECMO, all right? So that's what the scope of the patient cohort looks like. They were young, thin, and early cannulation, okay? We put balloons in them, and we set the PEEP to the balloon, where that balloon told us to set the PEEP. Otherwise, the strategies were totally different. So really, the dependent variable is, how do you set PEEP? Empirically, 10, 10, 10, or according to an individualized approach for this particular patient. I'm going to skip through the respiratory mechanics. You'll have to trust me, the mechanics were better if I put the balloon in and set my PEEP according to the balloon. What did, there we go. Cytokine levels in terms of injury, right? Inflammatory markers, they were so much lower with esophageal set PEEP, because we didn't have attic trauma. We mitigated a source of lung injury. And the main clinical endpoint is kind of where I want to get to in terms of successfully weaned, which was their primary outcome, and 71% of the patients that had PEEP set according to esophageal manometry were successfully decannulated versus 48% in the 10-10-10 group. All right, statistically and clinically significant difference in terms of their run on VV ECMO. And then the 60-day mortality also reached statistical significance, 32% on the balloon set PEEP, 54% on empirically set PEEP, all right? And so therein lies, that's a Kaplan-Meier curve there. And so you can see the statistically significant difference in terms of mortality as it goes out, all right? So I'm done, all right? I'm not gonna go over, I promise. What's it? You're good. I'm good? Okay. And what I didn't do, there's a couple little fluffy slides about proning and that sort of thing. What I didn't do is leave a whole lot of room for questions, all right? So I apologize. Does anybody have a quick question or like, I saw this, I saw that. In the end, the comment is, well, if we don't put them on the ventilator, then we won't hurt them, right? Hence this huge push towards awake ECMO, right? I think my commentary on that is that pretty good, let's try it out. But what you have to really kind of feel, just from the patient side, is that there is a biomechanical feedback in terms of lung stretch receptors. So if the lung is, patient's extubated, no pressure, lung is completely airless, and that patient goes to take a breath and doesn't expand their lung, they flip out. By all means, you would flip out. Has nothing to do with drive. You could be sweeping their CO2 almost to apnea, but if you let them start to take breaths in an airless lung, patients tend not to do well with that, right? And so they require a lot of neuro management. So something to think about as we take our step towards this more awake. We do a ton of awake ECMO, and that is the struggle. It's like, oh my gosh, we are having trouble controlling respiratory effort now, because the patient on the other end responds to that by pulling harder. And so they end up looking really terrible with a huge worker. I'm not talking about tachypnea. I don't care how fast they breathe. I care how hard they're pulling in, right? Because that's injurious to them, all right? And so there's that to think about in terms of there. We did a brief run, and I will say this kind of off the record, I have no data to show you yet. I have nothing. We did a brief run with negative pressure ventilation. And so we put a chest cuirass on them, kind of like a mini iron lung, and tried to pull their lungs open as opposed to pushing pressure in. Kind of an interesting thing. We did a run of about 7 or 8 patients, and we had kind of mixed success. Hopefully I can kind of work towards writing that case series up and kind of putting it out there. But that was an interesting ideas about kind of like what you're doing. Don't protect the lung or withdraw the ventilator, but now then you're stuck in an airless lung. How can I just reopen it that way? Okay? All right.
What's a normal esophageal manometry value?
There is, go ahead, keep going.
What does that offset? Does it offset it higher? What does that do?
So there is no normal, put it that way, because it's based on really body habitus, chest wall pressure. I will tell you a roundabout figure, right? If I put one in you right now on exhalation, it would probably be around 3 or 4, 5, which is why your physiology has a built-in PEEP around that, because it.
Muscle relaxants?
No, actually muscle relaxants do a little bit on the opposite side, because then the chest wall closes and is now stiff and doesn't move. And so it actually kind of is almost like a binder on their chest in terms of that way, all right? So it actually works in the exact opposite way. Cool? So I'll give you kind of roundabout numbers. A patient that has a BMI above 30, their esophageal pressure for exhalation is going to live in the high teens, 18, 19, 20, around in that area. Patients with BMIs greater than 35, I find that whenever I put these in, they're in the mid-20s. So if you think about this and you're looking at the situation blindly, that's what's happening just based on body habitus. All right? So it's hard to say a normal, but in my experience, I put in hundreds and hundreds of balloons. That's what I see. All right? But that's the roundabout area for esophageal pressure or pleural pressure based on body habitus alone. Okay? Anything else? We're good? All right. Okay. Thank you, guys. I appreciate you. I am pro education. I'm open source. So if you want any of these slides, I'm more than happy to share them. All right. That's my email up there. If you email me.